afternoon, everyone. Again, I'm so glad to be here talking to all of you. And it always makes me very, happy that so many of you are interested in these sessions. And the interest you are showing actually makes me going. So without any further delay, let me start the session. Before starting the session, if you had come expecting me to talk about step by step of a procedure, of the procedure itself, you will probably not get that. So what I'm going to tell you is step by step of doing the procedure right from the start. Now, because preparation starts with preparation. So I'll talk a lot about preparation for the procedure and then touch on the steps for the best practice of the procedure and then how we can maintain the catheter without any infections. So that's what I'm going to talk about. It's going to be an all-round step-by-step procedure, not focusing on the procedure itself, because I know all of you are experts in the doing the procedure. So let me share the presentation. Okay. Now, there are 10 steps, in to excel in urinary catheterization. It starts with prepare. You have to prepare as for a sterile procedure. And then gather the equipment, the trays and supplies, what is needed. Otherwise, you will be in the middle of the procedure and you will find that something has not been there, and therefore, the procedure, the sterility of the procedure may be compromised. The third is remember the applied anatomy. Fourth is setting up, lighting, access, and choosing the right catheter and size. And five is, though it should be in the beginning, at least before inserting the catheter, ask yourself, is it really necessary to do this procedure? And then we will, as I told, only one step I'm going to talk about, insertion, upskilling, and I will only touch upon what is the best practice in insertion, because all of you already know how to do it, but how are we going to upskill it to the next level? The seventh is fixing, very important. The catheter should be securely fixed. Eighth is maintaining the catheter and the drainage bag so that you don't give chances of infection and catheter-associated urinary tract infection, otherwise known as COTI. And how do you prevent COTI? By using bundle care. And finally, we'll talk about how you do constantly improve this practice by training and auditing your practice. So we have a lot of ground to cover. So let me start from the first, preparation. Very important, you have to remember that urinary catheterization is a sterile procedure. You're actually putting a tube into the inside of the patient's body, and that requires to be done as if you're operating on the patient. That is what is known as a sterile procedure. So it is a sterile procedure. The only difference is you don't take the patient to the operating theater. You do the procedure at the bedside. So when you do this, a sterile procedure at the bedside, you are not as careful as you are in the operating theater. And many compromises can take place in the sterility, in maintaining the sterility of this procedure. And that is the reason the incidence of catheter-associated urinary tract infection is so high. Among all the hospital-associated infection, COTI is the top. And this is the reason that we are doing a sterile procedure at the bedside. So how do we do it? You should follow all the principles of sterility, but I also want to introduce to you the concept of antiseptic non-touch technique, ANTT. What does it mean? You have to do this procedure by avoiding to touch two or three things. One is the key parts of the equipment which are being used, and maintaining the key sites. The sterility is around the procedure you're doing, that is known as the key site, and you don't touch the inside of the wrappers or touch the actual urinary catheter or the connections when you're going to put without maintaining sterility. If you're not able to maintain sterility, then you should not touch those parts. Okay, even if you're maintaining sterility, it is always advisable not to touch the key parts. Now, there are two types of ANTT. One is known as the surgical ANTT and another is the standard ANTT. What is the difference, you may ask? So this is the difference. The surgical ANTT is used when the procedure is complex and the duration of the procedure is more than 20 minutes. When the key sites are large and open and key parts are several. Now, this is usually in the operating theater. The standard ENTT, the procedure is simple, like urinary catheterization or inserting a central line catheter. It's a simple process. The duration is usually less than 20 minutes. Key sites are small. So for a central line or a catheterization, the amount of sterility you have to provide is quite a small area compared to an operation or a surgical procedure you're doing. And the equipment also has got only few key parts. So that's the difference between surgical ANTT and standard ANTT. So even in standard ANTT, it is best to use all these the principles of sterility. That is, you should not touch a non-sterile area, or hand should not touch a sterile area. That is the crux of this principle. Now, key sites, as I told you, the example, large meaning in an operating theater, you can see, there is so much of sterile area. It's difficult to maintain it unless you are in a specific operating theater, dedicated area. Whereas in urinary catheterization, the key site is small, and that's the reason we are doing it at the bedside. The key parts in in the urinary catheterization is the two things. One is the urinary catheter. So as it is mentioned here, these are the key parts. So the tip of the catheter, the balloon, the drainage port, and the balloon port. These are things which are coming with the non-sterile area. So this is sterile and it is coming with the non-sterile area. So this key part should always be kept not touched at all. And if you're going to use it for a long time, whenever you're going to access it, you've got to disinfect it using a technique known as scrub the hub. It is nothing but using an alcohol swab, and with it using a twisting motion, you scrub that area for 15 seconds so that the organism count comes down. So this is for the catheter. Another important thing to remember is the whole length of the catheter is sterile. So you should make sure that you don't touch this at all. So I will tell you how to avoid this as we go along. But remember this, the whole catheter is a key part. And in the urine bag, the highlighted areas are the key parts, where it is getting connected to the catheter and where you are draining the urine every day. So these are key parts and this should be kept clean. And whenever you are accessing it, you should use the scrub the hub technique. So that's the first thing, okay? So your mindset should be that I am doing a sterile procedure and therefore I've got to be careful. So second is gathering the equipment, all the trays and supplies. So it is worth, sort of dividing this into sterile items and clean items. Of course, the catheter and the bag are the key items here and they should be sterile. In addition, you should always use a sterile lignocaine jelly. You cannot use a lignocaine jelly which is on the shelf and then a person who puts his hand and then you squeeze the gel onto the patient's glove. I mean, on the person who's doing the procedure's glove, from a lignocaine tube which has been lying in the shelf maybe for weeks or months, that will be contaminated. So every time you use a urinary catheter, you got to use a sterile lignocaine gel tube. And the second is to inflate the bladder, you should use sterile water. One of the reasons for not deflating the bladder is when you when you're using saline or some other water, you should only use sterile water. And of course, you should use sterile gloves and sterile syringes when you're using a catheterization. So much for the sterile items. So in addition, you will usually have a sterile catheterization tray, which should contain a sterile central hole towel,
a sponge holder, a kidney tray, a small bowl to hold the antiseptic, either chlorhexidine or betadine, and a sterile gauze. Okay, so that is a sterile. All these things are sterile items. Now we are coming to the clean items. Of course, you should have the betadine to clean that area. You need a absorbent pad to make sure that the table and the bed is not soiled. You need 2 or 3 inch micropore tape to fix the catheter. I'll be talking about securing the catheter later. And then to protect yourself, you should wear a PPE and do a hand hygiene. And these are the items you got to collect. Okay. And the third step or third point to excel in urinary catheterization is to remember the applied anatomy. So what is the applied anatomy? You have to remember. So the female and male urethra are totally different. So the female urethra is only 4 centimeter long, whereas a male urethra is 20 centimeter long and it is angled at different areas. So when you're putting a catheter into a female urethra, remember it is only 4 centimeters. So there's no point putting the catheter fully inside. So it will only get coiled in the bladder. Whereas in a male urethra, you got to insert the catheter up to the junction between these two things, the outlet and the balloon insertion tube. So it has to go up till here because it's a long one. Otherwise, the balloon may be inside the urethra. Very important point to remember. Now, you also have to remember that the male urethra has got 3 areas where the catheter can potentially get stuck. These are known as constrictions in the male urethra. So one is the pre-pubic angle, the other is the infrapubic angle. That is because the pubic bone is here. So that's the pre-pubic and the infrapubic. And then the prostatic urethra is the narrowest part of the urethra, and sometimes the catheter can get stuck here. So that is the reason when you catheterize, you got to hold the penis horizontally or a little bit in an angle facing the ceiling so that these angles get straightened out. So that's the reason you need to know the anatomy of the male urethra. So the fourth thing is setting up. Okay, so you're prepared, you got all your equipments all in place, you now understood the anatomy. Now you need to prepare yourself so that you get the procedure done without much of an effort. So this is known as ergonomics. You place yourself in the right position for efficient functioning. So first is having adequate lighting, and you need to have access. Make sure the tray is on your dominant hand side. So not on this side. Otherwise you'll be reaching. So dominant hand side so that everything is easy for you to do. And choose the right catheter size. Very, very important. And also use the right catheter type. So let's look at each one of these. So this is setting up. You can see how the tray is on the dominant hand side of this particular person. Now, how do you choose the right catheter? So there are 3 types. One is the intermittent catheter, where you just use it once to drain the bladder. So this is used either to obtain a sample or to empty the bladder. Self-catheterization in people who have problems in emptying. It can also be used in acute urinary retention or after surgery, where you expect the retention not to recur. So these are intermittent catheterization. And the indwelling catheter is the usual one we use. We usually call it a Foley's catheter, and it is used to keep the bladder empty and prevent urinary retention. In addition, you have long-term use. Mostly these are silicone catheters, and sometimes in males you can use what is known as a condom catheter, so that you don't actually use an indwelling catheter and avoid clotting. Okay, so these are the 3 types of catheters. So choose the right one for your purpose. The second is catheter size selection. So what we have to remember is the French size which is there actually is the circumference of the catheter, not the diameter. It's a circumference. So you put a tape and pass it around. So that is the in millimeters. So 0.3 millimeters is equal to 1 French. And here you can see, so the catheters vary in size from smallest 3 up to 18 or even 22, 24, 28.
there are different sizes available. So we just a nice diagram showing the centimeter scale, the inch scale, and the French catheter scale. Okay, so that's something you should have to remember and choose the right catheter size. Now, this is a table which shows what are the sizes to be used. So it starts from the preterm infants from 3.5 to 5 up to an adult up to 12 French. So in large adults, you can use even 14 French. Now, if you are using it for therapy, that is, if the patient has got hematuria or debris and you want to irrigate the bladder, you need a much bigger catheter size up to 16 to 20. And if you have done a procedure, for example, prostatectomy, and you want to irrigate the bladder, it is better to have a large catheter up to 22 French. And these usually have a triple lumen, where one lumen you can irrigate and the other one is the outlet. And because of the large lumen, any clots which are formed can easily come out of the outlet tube. So this is standard, and using these tables are easily available on the net, and you can use this as a guide to choose your catheter size. Now, as I told you, asking is it necessary should be done even you get ready for the procedure. But I put it so that at least before the insertion step, you need to be understanding what are the indications. So these are the indications for putting an urinary catheter, and these are the only indications. If your patient does not fit into any one of these indications, you should not put the urinary catheter. Okay, so urinary retention or obstruction, severely ill immobile patients, lack of bladder control, maybe because of neuropathy or paraplegia, perioperative for a short period, selected surgical procedures, in maybe assisting the healing of pressure ulcer or any other wound healing in that area where you think urinary incontinence may be a cause for delayed wound healing. And finally, a soft indication is patient request and end of life to just to give comfort to the patient. So these are the indications. Some of them are absolute indications. And the last one, the patient request end of life, is a soft indication for putting. So as I repeat it again, if there's if you're putting a catheter, if this is not in any one of the list, then you really have to reconsider. Or maybe you have to, in a male, you can consider a condom catheter. Now let's go to the insertion. That's the 6th step. So the insertion is upskilling to best practices. As I mentioned before, all of us know how to put a catheter, but how do we do it so that it doesn't cause trauma to the patient? It is not done in a way that is introducing the infection at the time of putting the tube. These are what are encompassed in the best practices. Now, I would classify the insertion itself into 3 stages. So what are the 3 stages? One is actually again explaining to the patient. Very important that you tell what is going to happen to the when they're going to catheterize. You should say, I'm going to put prepare the skin so you'll feel wet in that area, and then I'm going to inject local anesthetic, especially in males, because when you put the lignocaine gel, it really stings. So you got to say you have a bit of stinging sensation. Warn the patient before, so that, so that they know what is going to come. So I'd explain before the procedure and also during the procedure. What I do is, as I keep doing, every step I will keep explaining. Now I'm cleaning. Now I'm putting a sterile drape overview. Okay, now I'm going to inject the, give the gel. Remember, I told you this will be a bit of stinging. So here is that step is coming. Like that, step by step, as I'm doing the procedure, now I will be explaining to the patient. Very important to explain during the procedure, and also explain after the procedure what is the aftercare they have to do while they have having the catheter in situ. Another important point is to get a chaperone if you're doing the catheterization of the opposite sex. Even if it is the same sex, it's better to have an assistant. Catheterization is not something which you can do solo. You definitely need an assistant. The chaperone can also be developed as the assistant. Now, positioning the patient, that for the male it is supine, and for the female it is with the legs bent and the hips open. Then you expose the area, and then you have to place the absorbent sheet underneath. So all this can be done clean. No, nothing of this is sterile. So you know this is the stage 1, and it involves more preparing the patient and explaining to them and getting the consent. Now the stage 2 is where the whole process becomes sterile. So ideally, even though you're doing it in the bedside, you need to scrub and don sterile gloves and gown as if you're doing a sterile procedure. You know, you wear the full in theater, you do the scrubbing up to the elbow, and then you put the sterile gown and then wear a sterile gloves. So this will make sure that whatever you are, handling, sterile things are handling, doesn't come and touch, with the non-sterile area. Common practice, everybody uses a plastic gown, just wears a sterile glove and does this procedure. Then you got to be extremely careful. You got to use the ANTT, antiseptic non-touch technique, so that you don't touch any of the sterile area, but only with the aid of a forceps or covering it with some other plastic or something like that. But it is much comfortable and easy for you if you don a sterile glove and gown, and it doesn't take too much of time. And especially if you are using autoclaved, it won't cost you much of money. Then prepare the area with the betadine or chlorhexidine solution according to your hospital policy. And then lubricate. Lubricate, be generous. Okay. So you have anyway opened the tube for that patient. So better to empty it so that the lignocaine gets into the whole urethra. I'm talking about the male. For the female, it's only 4 centimeters or 5 centimeters. So just lubricating the tube should be enough, because you can't actually inject the lubricant into the female urethra. It will only go into the bladder. But for the male, you need to empty the whole tube and make sure that you sort of catch the urethra with your thumb, and so that the gel does not come out. So it stays in for at least 5 minutes. This again, a lot of us don't wait. We just put in the tube and then put in the lubricant and then start catheterizing. There is not enough time for the local anesthetic to act. So as I told you, I'm talking about the best practices. And you should place a sterile kidney tray below the urethra so that to catch the urine. So all these are best practices: wearing scrubbing up to the elbow, sterile gloves, gown, preparing the whole area with betadine and chlorhexidine solution. Whole area meaning from the lower part of the umbilicus to the mid thigh. You have to widely prepare. Then put a central whole towel and then lubricate the gel. Another important thing is, once you have used the left hand to hold the penis, you cannot use it. The rest of the procedure has to be done one-handed. Right. The third is actually the insertion. So when you're doing the insertion, as I told you, the whole catheter is sterile. So how do you make sure that you don't touch the catheter directly? The manufacturers actually have given you a solution, because inside is a plastic wrapper. And there is a perforation at the tip of the wrapper, and you can actually give it to the helper, and the helper can snap it out. So only the tip of the catheter will be exposed, and you've got to do the catheterization, holding the catheter over the plastic sheath. And then as you keep inserting the catheter, gradually you pull the plastic sheath out, so that at no point in time you're actually holding the catheter with your gloved hand. Yes, your gloved hand is also sterile, but in spite of it, though you're using a sterile glove, it is best practice to use non-touch technique. So that is the reason we do this. Then in the male, as I told, insert up to the junction, that's known as a hub, between the outlet tube and the bulb tube. So you have to go up to that, so that the bulb is definitely inside the bladder. Then you check for urine drainage and then inflate the balloon. So these are the best practices in the 3 stages of one is getting prepared and exposing the area, placing the absorbent sheet. Next is preparation of the skin, the lubrication, and making sure the urine drainage is into a sterile kidney tray. And finally, using non-touch technique to put the catheter in. making sure that the bulb is well inside the bladder and then inflating the balloon. Now, how much water should be used to inflate the balloon? Normally, there will be something, the ml written on the catheter itself. Usually, it'll say 20 ml, 30 ml. But the general recommendation is inject 10 ml. Why is this? Because using more than 10 ml will inflate the balloon, and this hitches on the neck of the bladder and causes irritation and painful bladder spasms, especially if you have distended up to 30 ml. 30 ml is the maximum capacity. So it's not that you've got to put in 30 ml. So inject, because you just need to keep the catheter so that it doesn't slip out, and 10 ml is more than enough. Right. That's about insertion. Now, one part of insertion is securing the catheter, but I have made it a separate step because many of us miss this. And the proper fixation minimizes discomfort of the patient. Imagine now having a catheter and keeps moving. So this will cause a lot of irritation in the tip of the urethra and painfulness. So just be kind to your patient by fixing the catheter securely. And by restricting the unnecessary movement, it has been proven that when you securely fix the catheter, the incidence of COTI goes down because this movement causes micro abrasions around the tip of the catheter, and through that easily the organisms can ascend up into the bladder. So that's the reason you need to securely fix. You can use ready-made things like that, or the best thing is to put a 3-inch tape on the patient's thigh, then use another 2-inch tape on top of that tape to make sure that the thing is securely connected. And then always don't fix it on flush onto the skin. Give a small mesentery so that the catheter can move. So these are all small practical points, tips and tricks you have to do to fix the catheter to minimize the discomfort and reduce the COTI. Now, we're going to go into the 8th step, which is maintaining the catheter and the drainage bag. So actually insertion, there is only little to say because at the time of insertion, if the patient is got COTI because of insertion, it is because of poor technique and not following the sterile guidelines. Okay, so this is if you follow all the steps which I have mentioned, you can actually prevent COTI to a large extent. But it is during this phase of maintenance that the infection comes down. I see Abhishek has raised the hand. I would finish the talk and come to you. Okay, so I don't want to interrupt the flow now. Okay, you can please keep the question till I finish my talk. Now, catheter drainage bag maintenance is very, very important. Now, first thing you have to remember is the whole drainage system is closed. So what do you mean by the closed system? So the connection between the drainage port of the catheter and the bag should not be disconnected for any reason as long as the catheter is there, unless if you're changing the bag. Okay, and the tap of the urinary bag should always be kept closed, except to keep it drained, and that makes the whole thing closed. Okay, when you unplug it from the catheter, or you don't maintain this drainage thing closed, at certain times, then it will become open and organisms can enter. Okay, so that is the reason now we call it a closed system, and it's very, very important to maintain this closed system. Now, another very, people don't think about it. So always choose a drainage bag with a tap in the bottom. Don't buy these type of bags where the tap is on the top. Always buy a bag where the tap is on the bottom. It's just common sense, right? So if you have to empty this bag, you've got to keep it upside down, and it's more of handling. Whereas here is very easy. You can keep the bag hung as it is and just open the tap and empty it. Ease of use, avoiding the urine going up the drainage tube, all that is possible. There is no difference in the cost. Okay, it's just that you have to ask your stores person to buy this sort of bag. Similarly, buy a catheter with a port. Because when you want to do a urine sample, if you don't have a port, you will either disconnect and make the system open, or you will put a needle through the catheter, which can actually damage the catheter. So again, buying a bag with a side port is not that expensive. So it is just that you got to be careful about these things, because this will help you in maintaining the closed system. So always buy a bag with a sampling port. Okay, so let's look at some best practices of maintenance. As I told you, collect the specimen through the side port of the drainage bag. If this is not available, you can use a fine needle, 24 size, and use a Z technique. Again, disinfect the area with alcohol swab, then put the needle and aspirate the urine. You can probably have to clamp the catheter for some time so that the catheter gets filled up and you get the sample. Okay, best is to use the side port. Then empty the drainage bag every 4 to 8 hours, or when the bag is half full, and especially before transporting the patient. Now, many times I see that the patient is on the stretcher with a full bladder, and when you're transporting, you'll actually keep the bladder on the stretcher, and very easily the urine can get retrograde into the bladder, and you can imagine all the contaminated urine is going to cause UTI. So before transporting, one of your SOPs should be that the drainage bag is completely emptied, and then only you will transport the patient. Otherwise, every 48 hours, or if the bag is become half full, don't allow it to become 3/4 or fully on. Very important. And then provide routine perineal care to the patient. What do we mean by this? Just clean it with either soap or water or one of those wipes you have nowadays. Using antiseptics is not necessary. It has been proven that using antiseptic to give perineal care does not prevent clotting. So just proper hygiene, that's all. Now, emptying the urine bag is actually done by a person who's low in the hierarchy. Usually it will be what we call the orderly or ward boy or ward girl or whatever you call in your hospital. So it's very, very important to train them to do it. So usually it is just done, go and empty the bag without actually training them how to do it. As you'll see, there are several steps to train them. So one is to perform hand hygiene before and after emptying the bag. So this is the 5 movements of hand hygiene. Wear a new pair of clean gloves for every patient and remove the gloves after use for every patient. Very important. The third is clean the container before you empty. Don't just keep using the same container without cleaning or from one patient to another. Before emptying, you got to train them to go and clean it with soap and water and make sure that at least it is clean. And before opening the tap, you need to do what is known as the scrub the hub. I already mentioned that to you. So you have to do a twisting motion for 15 seconds to reduce the colony count in that area. And then you have to do that before and after emptying the bag. Avoid contact between the outlet tap and the drainage bag and the container. It is very obvious. And then after that, document the urine volume in the output chart. So urine output is one thing where either it is estimated or what I call guesstimated. So most of the time it is guesstimated. Now you just guess, oh, maybe it's 200, 300 ml. No, write it down. So don't do that. You actually have to measure it and write it in the chart. That is the estimate. And finally, discard the urine and flush it. Okay, so these things, if you do it as a mini training session to these people who actually empty the urine bag. When to change the drainage bag? So routine changing at fixed intervals is not recommended. So you should change the bag based on clinical indications, such as if you feel the urine is turbid, or you are suspecting infection or obstruction, in the tube, or if you had to do open the system, then the whole thing has become open. So better to use a new bag for that. So these are the only indications where you have to change the drainage bag. So another few points on drainage bag care. So place it in a dependent position, 12 inches below the level of the patient's hip, at least 1 foot below the patient's hip. And do not rest the bag on the floor, and keep the tubing free from any kinks or twists. Very important. All these are practical, common sense advice. And if the tube has to be raised for any reason, clip it before you do that. Don't allow the urine to drain back into the retrograde into the bladder. Another very important point missed is you have to keep the tubing at above the level of the drainage bed. Don't do this. It's like the commode U-bend. Okay, so if you make an U-bend like this, there is going to be stagnant urine here because it's not draining into the bag, and this can flow back into the thing, or organisms can ascend through the tube and cause urinary infection. So never have a dependent loop while hanging the bag. So these are all points which you have to remember. As I told you, I'm talking more about maintaining than actually inserting the bag, inserting the catheter. And finally, certain don'ts. So here is do not apply clamps, especially metal clamps. It will destroy the inflation channel and prevent removal. Do not break the closed system. Do not disconnect the catheter from the urine tubing. I think I mentioned this several times. And do not place additives such as antiseptics and microbial solutions in the drainage bag. Doesn't work. Okay. So don't do all these things which are not proven by evidence. Then let's talk about certain troubleshooting. Many times we run into problems and how to solve these things. So we will classify these as insertion problems. What if there is bleeding when you catheterize? And after you catheterize, there is non-drainage of urine. So insertion could be because of gross edema. So what you do is you hold the, especially the male, the penis should be held vertical and maintain circumferential pressure to get the, edema out, and it'll sort of make it better. If this fails, you have to instill jelly into the preputial opening and then aim the catheter at 6 o'clock. That's where usually the meatus is. Mostly you'll be successful. If after 2 or 3 attempts this is not successful, then you got to escalate it, because if the patient is in acute retention, then you either have to do a dorsal slit or a suprapubic catheter. So it requires a surgical expertise. So you have to escalate the what you need to do. So other thing is, as I remember anatomy, there are certain angles in the urethra where it can get stuck. So very important to instruct the patient to relax, deep breaths with mouth open, and you don't sort of push it in jerks. Gentle pressure, and you'll asking the patient to relax slowly. You'll get past these angles. And sometimes the bladder neck is very acutely angled, so you may have to use a Cody tip. Cody tip is nothing but a catheter with a right angle or even obtuse angled tip. So that will get you into the bladder. So this is usually done by specialists. Now, what if you put the catheter and there is some staining of blood on the side of the catheter, or there is some light red coloring of the catheter? If these are slight, then it can be ignored. But if there is a steady stream of bleeding from the catheter into the drainage tube, then there has been urethral trauma, and again you will have to escalate the care to a urologist or a specialist in your hospital. So stop insertion. You can give pressure over the shaft or bulb of the urethra for about 10 to 15 minutes. So this means that you have to stand there and give the pressure. You can't put any bandage there. No, not practical. And do not attempt, very, very important, do not attempt reinsertion immediately. Call for help. Let an expert do it. And wait for a couple of hours before reinserting, because the patient will be an anxiety, and there'll be spasm, so better to wait. And if it is urgent, there is no option apart from putting a suprapubic catheter, because if there is bleeding, then you don't want to do recatheterization immediately, so you have to put a suprapubic catheter. So now don't forget, sometimes the blood may be because of the procedure done and it is coming from higher up. So that also can happen. So you need to be knowing about the patient's history so that you don't get alarmed unnecessarily. The non-drainage. Now you put the catheter and no urine is coming out. The most common reason is the jelly is obstructing the eye of the catheter. So you can actually flush it with 5 to 10 ml of saline or give suprapubic pressure. Usually this will solve the problem. But if it is not draining, be very careful about inflating the bladder. So make sure you're inside the bladder. If you are not sure, better to tape the catheter and then get an ultrasound. Make sure that the tip of the catheter is inside the bladder and then inflate the balloon. Because if you inflate the balloon in the urethra, it will cause severe urethral damage and result in stricture. Stricture becomes a lifelong problem to the patient. So by a simple mistake, we cause a lifelong misery for the patient. So you should avoid it by just taping it and then getting an ultrasound done and making sure the tip is actually inside the bladder. Now, this is when you are going to remove the bladder. The most common problem is the balloon will not deflate and you cannot pull out the catheter. So the primary reason is that malfunctioning of the inflation valve, or sometimes you put some other solution like normal saline into the balloon instead of water, and this crystallizes and it causes wrinkles like this. So the catheter will not come out. So this you have to avoid. Now, if you cannot deflate, that you got to go a step-by-step methodology. So one is advance the catheter so that the balloon is inside the bladder, and you cut the balloon port proximal to the inflation valve. So, the inflation valve is where you put the syringe in. It's a one-way valve. Only when you put the syringe, you can push the saline. Once you take the syringe out, nothing will come out. So proximal to that, you cut the inflation tube, and then you can put a guide wire. Usually what you use for central line, a fine guide wire will go through this inflation port, and once it is there, usually around the guide wire itself, the water will come out, especially if there's been incrustations or crystallization. But if this doesn't happen, then just like a central line, you got to thread the small fine catheter over the guide wire, and that will get into the balloon. And then you can pull the guide wire out and the balloon will deflate. So this is the method where without trauma, you can deflate the balloon. Don't do methods like hyperinflation with air or saline, or using ether, chloroform, or acetone, or mineral oil. All these are dangerous, irritate the bladder, and will cause morbidity. So don't do any of these techniques. So if you are unable to empty the bladder, again, the preferred technique is ultrasound-guided balloon rupture, where a sonologist under ultrasound guidance will put a fine needle in the suprapubic area and burst the balloon. So that's the safest way to do it. Okay. So this is how you non-deflating balloon, you approach that. And the penultimate one is prevent catheter-associated urinary tract infection. Here you have to use what is known as COTI bundle. Bundle care is very important to prevent COTI. So what is a bundle care? Before we get into it, you should know the statistics. 15 to 25% of hospitalized patients may receive short-term indwelling urinary catheters. Dr. Nitya told in the beginning itself, it is one of the commonest procedures done for an inpatient next to an IV cannula. And the COTI rates over the world, this is CDC data, 3.1 to 7.5 infections per 1,000 catheter days. So COTI is always measured per 1,000 catheter days. The number of days, in a particular month, your patients have catheter. So the infection is 3 to 8%, let us say. Higher in the ICUs. And the tragic part again is more than 50% of these COTI is preventable. So many of these patients develop ascending urinary infection, pyelonephritis, go to the ICU, and sometimes even die because of a simple catheter that we put inside the bladder. So very, very important to prevent COTI, and that is why I use the bundle care. So bundle care minimizes COTI by making nurses and doctors check three things. Should the catheter be inserted? Indication. No, I'm again repeating it here. It is in the bundle. Right technique for insertion. Now, those best practices I mentioned in the, one of the steps, I think sixth, I think. And has the catheter being maintained properly? This I have explained in detail. So these three things are there in the COTI bundle. It's called bundle because all these three things are bundled together, and use this every day on the patient. Okay, so you have a checklist where you put all the indications as a checklist, and if you cannot tick any one of these, challenge yourself and challenge your senior, challenge your doctor whether this patient requires a urinary catheter. And then while inserting, use sterile technique. We went through the steps, the 3 stages of insertion. So sterile technique, hand hygiene, sterile gloves, sterile lubricant, sterile urinary catheter, sterile bag. So sterility, sterility, sterility. This is a sterile procedure done at the bedside. Remember that. And finally, the maintenance group. So these are all, I already spoken about it. It comes as a checklist in your COTI bundle. So every day, these things should be checked by the nurse who's taking care of the patient, and either the link nurse or the COTI nurse will get the data. So the final step is to audit and do surveillance to make sure that your COTI rate is low, and also train your nurses, doctors, and other people who are maintaining the catheter to make sure that this bundle care is followed. So COTI surveillance is used for those who are either intermittent or continuous indwelling catheter. So everybody should be included for COTI surveillance. So you will need information on indication, on the duration of catheterization, how long it was in place, any catheter related complications like bleeding, infection, or other things, and the removal of catheter. When was it removed? When and for what is the indication? Okay, so these are the basic things you follow in the COTI surveillance. And finally, you've got to train on the principles of sterility and ANTT. Tell them about this difference between sterile and clean procedures and the use of antiseptic non-touch technique. Train them. What are the indications and what are the best practice for insertion, and especially train them on maintenance. So if you do all these 10 steps, then you would actually excel in urinary catheterization. Not only will you excel, you will reduce the complications. So summary is just my 10 steps. So prepare as for a sterile procedure, gather equipment, trays and supplies, remember your applied anatomy, set up the lighting, the right axis, the right catheter, and right size. Ask if it is really necessary. Insertion to the best, upskill yourself to the best practices. Fix the catheter securely. Maintain the catheter in the drainage bag as long as the catheter is in situ. Prevent COTI by using the COTI bundle. And finally, audit, do surveillance, train, and improve your practice continuously. Thank you so much for your kind attention. I hope, by following all these 10 steps, as a group, we can bring down the complications of COTI and other things in our hospitals. Thank you so much. Again, I am so overwhelmed by your attention and the number of people who attend these seminars. Thank you so much.
So thank you so much for joining us. I wish you all wish you all enjoyed the session, and we'll be seeing you next week, same time. Thank you.